Welcome, everyone, to our webinar today, where we're going to talk about your voice matters, and it truly does matter at the bedside. And we're going to talk about how we can drive clinical change from the bedside. So, I'm Nicole Kupchik. I am a clinical nurse specialist, and one of the roles of a clinical nurse specialist is to do just that, is to drive change at the bedside. And one of the things I have to say as a clinical nurse specialist, I always try to be very in tune with the bedside nurses because I will tell you, I always say the bedside nurses are the ears and eyes of the hospital and can really relay issues that are happening so that change can happen. Because how many of you go to your toolbar and just raise your hand if you've ever felt extremely frustrated with practice or something that's repeating at the bedside and you're just like, why does this keep happening? So a lot of hands are going up right now. And I think all of us have felt that. And in fact, that's why I went to school to be a clinical nurse specialist, is because I wanted to implement change. So I'm joined today by Cindy Cadwell. So Cindy is an advanced practice nurse, both as a clinical nurse specialist and a nurse practitioner. And she works at the Hawaii Pacific Health Medical Group and has done so much work in quality. And I'm just so excited to be joined by her today. And she's going to talk through some amazing projects that she's worked through implementing change at the bedside. So super exciting. And then, of course, Kathleen Volman is joining us. So Kathleen is a fellow clinical nurse specialist as well. And she has worked she owns her own company right now and does consulting with hospitals all over the country and actually internationally as well. But she's worked many, many decades at the bedside as both a bedside nurse and clinical nurse specialist. And one of the things I just want to toot her horn a little bit is Kathleen is the president of the World Federation of Critical Care Nurses. And this is a really big deal. It's a super big deal because she's on the international stage and works with nurses from all over the world, from Europe to South America, Mexico, Africa. And so just a huge, I'm very proud of you for the work you're doing there, Kathleen. So I know I feel like sometimes you get imposter syndrome. I'm joined by two amazing nurses here today. And we just want to say a huge thank you. This webinar is being sponsored by Aseptoscope, who has done a lot of work in quality and decreasing hospital transmitted infections. So we're really excited to be sponsored by them. So here are disclosures. This is a CE accredited program. So I want to just be super transparent and disclose anything that might be perceived as a conflict of interest. So here's our objectives. We've got a lot that we're going to plan to get done today. So we want to talk about the critical role of frontline perspectives in identifying any risks, generating solutions, preventing patient harm. And, all of this goes down to safety and really, making our practice as safe as possible. We're going to talk about strategies to communicate and advocate for change. And this, because I'm sure a lot of you have felt like, where do I even start with this? And then we're going to talk about how at the bedside you can transform things that you're seeing into actionable, innovative improvements that can really help quality and patient safety. And so this is what to expect in our agenda today. So we're going to talk about the power of the frontline bedside nurse who absolutely is the voice and can help make change. We're going to talk about preventable harm when risks are known but often ignored. Human factors and near misses. So we're going to have some interesting discussion on near misses. We're also going to talk about how we take our observations at the bedside and drive change at the bed clinically. And then we've got a couple of case studies. We're actually going to go over an amazing case study from nurses who implemented change at one of the VA hospitals. So we're going to chat about that. And then we're going to talk about just tools and strategies. And then we're going to take any questions you've got. And so one of the things I do want to say is if you have comments, questions, get them into the chat, the Q&A. I'm going to be monitoring that throughout the entire presentation, and we will get as many questions answered as we can during this webinar. All right, so with that, I'm going to launch our first poll. So what you're going to see in just a minute here is you're going to see a polling question that pops up. And the one thing I want to say is all of the polling is anonymous. We can't see how an individual is answering. We can only see how the entire group is answering. So we want to know, first of all, who's with us today? So get your votes in. Let me know who's here today. We want to know your role. And then if you are saying other, if you wouldn't mind in the chat, write me a note and let me know what your role is. If I don't have it listed here, let me know what your role is. Okay, we've got lots of votes coming in. Oh, I thought I
Educate.
had educator on the list. I don't know why. I thought I had that as one of the options. Okay, I'm so sorry. Okay, so thank you to the educators who are here today. I honestly thought I had it on the list, so I'm so sorry about that. Okay, so we've got a clinical nurse leader. What is CAO? Is that chief? What's CAO?
Advocacy officer.
Maybe. Leah, let me know what CAO
Analysis, yeah,
or yeah, what does CAO stand for?
analytic officer.
Okay, so we've got assistant nurse managers, quite a few educators. Oh, chief
Administrative officer.
administrative officer. Okay, thanks,
Ah,
Leah. I wasn't sure what that stood for, so thank you for clarifying that for me. So, okay, so it looks like quite a few educators, and I'm so sorry. I truly did think I had that in there. Okay, so lots of educators. We've got
What are
some.
our polling results?
Yeah, I'm gonna go. I'm just going in the
Cool.
chat right now. So, oops. Here, hang on. Sorry, I just accidentally went a little too crazy here. Okay, so I'm going to end the poll in 5 seconds. All right, let's see who's here today. All right, so it looks like 27% are bedside nurses. So we're so happy you're here. Thank you to all of you. 11% managers. We've got 29% clinical nurse specialists. So woo woo, we drive change, right? So a lot of bedside nurses, you always should know who your clinical nurse specialist is. And then quality, and then I think we got the people, all of the nurses who said other in the chat. So thank you for answering that question. Okay. All right, so now what we're going to do is I'm going to turn it over to Kathleen, who's going to talk about the power of the frontline voice, because truly, those at the bedside can really drive change. So take it away, Kathleen.
Thanks, Nicole. And you alluded to the fact that without that frontline voice who touches the patient, touches the systems, it makes it very difficult to figure out what are the issues and where change needs to take place. So that frontline voice is critical. So I wanted to start before because we are talking about innovation, and sometimes we think innovation is only a new technology. And I want to make sure that we're starting with a good baseline of what that definition of innovation is. It's the intentional introduction or application within a role, a group, which could be your unit or an organization, and it can be an idea, it can be a process. Yes, it can be a product. It can also be a procedure. And this means it's new to a relevant unit of adoption where it's designed specifically to impact or benefit an individual, a group, or the wider society. And you consider the wider society could be the profession of nursing, could be your organization itself. So innovation isn't just about new tools, it's about new thinking, the relationships, and the way of caring. So when we talk about new thinking, it's challenging those assumptions. How many of you have had to jury rig something? Work around something? Go ahead and put your hand up in the or use a emoji in the side effects of the Zoom. Yeah. So we're challenging those assumptions so that we can reimagine that care. We're building collaborative partnerships. We are the coordinator at the bedside for those care. And so we see the integration of different disciplines and different departments and how they work or don't work together as a part of it. And also innovation can be new ways of caring, creating a patient-centered approach. The staff I partnered with when I was at Henry Ford Hospital, we created a bereavement program that followed families out for a year of the patients that died in our unit. That was a very patient, family-centered approach, new program, innovative at that time. Now it's out there for the world. So that tells us. But we are catalysts for the innovation. Why? Why? Because we are frontline observers. We're at the bedside witnessing what works, what doesn't, and precisely what systems are breaking down in real time. And if we don't tell anybody, then those systems continue to break, and it affects our workflow, it affects our ability to do the right thing, and it affects our patient care. We are critical thinkers in everything that we do. We're rapidly assessing those situations and developing practical solutions. And by the way, those practical solutions can turn into solutions for your unit, your hospital, and the profession. We're collaborative leaders because we're the natural bridge for a lot of disciplines in meeting the goals for our patients. And we are persistent champions to try and make the right thing happen, to see improvement occur even in the face of resistance. And we are trusted voices. We've won that trusted space now ever since they've done the poll. We're the most trusted profession. We need to leverage that to be the catalyst for the innovation at our bedside. So let's talk about some aha moments. And by the way, if you want to share an aha moment that you had in the chat box, feel free. What is it? This is a breakthrough innovation that can emerge from a simple observation that you've made as a frontline clinician because you refuse to accept that's just how it is. First one of my colleagues, a company came to him and said, hey, we want you to study our oral care product. It wasn't in a structure that made it easy for the frontline staff. So he looked at him and said, no, unless you turn it into something that makes it easy for the staff to do the right thing. And that's how the 24-hour kits came about. I manually proned people in the 80s. I thought the likelihood that nursing was going to do that with a striker bed or a circle electric bed was about 0 to none. So I created a positioner that helped prone people and sort of demystified the ability to do that. The staff I partnered with, they were awesome at diarrhea, but not so good at constipation. We recognized that, and they sat down with our pharmacy partners and created a bowel management protocol. This was in the 90s. This protocol is still in existence today. Passive disinfection systems. How many of you have worked, when it was the 15-second scrub the hub, whether that actually occurred or not? Put a cap on it, make it easy for us to do the right thing. And lastly, we know that stethoscopes are like our hands. They carry the same burden of transmission. So a simple disc cover that allows us to put it on the stethoscope, take it off after we use it with the patient, can really reduce that contamination. So each of those innovations started with a staff, with a person asking the question, there's got to be a better way. But we know there are barriers to speaking up. Have any of you ever heard this phrase? That's not the way we do it here. Now, needless to say, it's that entrenched resistance to new ideas. And I don't have a problem with that statement as long as what follows it is because the evidence supports we need to do this. Or it may be, I'm a new nurse. There may be power dynamics where I'm a less senior and therefore I can't speak up. You can speak up. Not sure where to start. Well, that's why you came to this webinar. Uncertain about the process channels of how do I frame the concern? How do I move it forward? And we're going to give you some tools for that. Internal fear ourselves, worrying about backlash, being labeled as I'm the difficult person. I got that label all the time. Because I was always asking, why are we doing it this way? What about this? And personally, as well as professionally, is there ever enough time? But a lot of these innovations can help us improve our ability to do that and improve our workflow. So innovation really thrives in respectful environments where every voice feels safe, heard, and valued. And so the concept of the healthy work environment partners with our ability to innovate. We need to have that psychological safety at our bedside as well as in our organizations to be able to move forward. But leadership depends on you. because at the front line, it is our voice because we're close to the patient and the problem as well as the solution. We make those keen observations. Every time you say to yourself, this is getting in the way, I did it this way, that's a potential opportunity for an innovation. And we can be nimble and find those feasible solutions. Your voice does matter. Patient safety and quality improvement depend on us at the front line stepping into those roles and advocating for change, the change that we need to know. The future of healthcare innovation starts with us. And the question I want to ask you is, will you answer that call?
All right. Well, we're going to launch another poll right now. So this is going to be poll number 2. And what we want to know is what would be the biggest barrier to implementing a new infection prevention solution in your unit? We're just picking like an example. Like if you had to think like, okay, in my unit or in my department or in my hospital, like what are barriers that like what do you think is the biggest barrier that you face in implementing change?
I'll be interested to see this one.
Yeah, I'm sure a lot of people are like, I want to pick more than one, but like if you had to like pick the biggest barrier, what would that be? Okay, 5 seconds.
I always want to do the Jeopardy thing.
Okay, so interesting. Okay, so the biggest barrier, 49% of the group on the line today said workflow and compliance. Okay.
Hi.
And then that was followed very
Not
closely
surprising.
by 37% said budget, and then 14% said leadership and approval. Okay. And luckily, a lot of these things are things you can tackle to implement change. All right, so with that, I'm going to hand it over now to Cindy, who's going to talk about preventable harm when we know that there are risks at the bedside, but they get ignored.
Thank you so much. And thanks, Kathleen, for setting this thing up so well with the issues and the problems associated with it. I totally appreciate the workflow and budget as barriers, and we will be talking about that. And hopefully, by the end of this discussion, you guys will have great opportunities to address those particular issues because workflow is our opportunity to improve. I'm going to be talking about preventable harm. Those two words, preventable and harm, should not be in our language. We should not have harm, and it should not be associated with us. So some of those the prevention is just basic nursing 101. This is what we do for a living. And I want to talk about the types of preventable harms that we are working with, in particular, the healthcare associated infection. When you call it a healthcare associated infection, that means we are the healthcare providers. It's associated with us. It's an avoidable adverse event. Avoidable. It should not be happening. Now, here is all the data on the mortality associated with it, the costs associated with it, which keep in mind budget issues, and more importantly, in my mind, is the healthcare costs associated with us as staff. It is not good to know that that CLABSI occurred in the patient that I took care of last week. Was it my fault? We don't know. And that's one of the reasons why it's really important for us as staff to really look at what are the issues that we see happening every day that we can make our voice heard and help to offset. Reimbursement, of course, affects everything, including the budget, meaning that we are reporting out these data. And if these data are public for the world, do you want to be associated with the hospital that has the worst rate in town? Probably not. It doesn't help your unit if your unit is the one that has the most CLABSIs, for example. So it's really important to us as staff to make our voices heard so we can, in fact, change the way things are occurring. So in this particular slide, I have the three pieces that I want us to make sure that we're looking at and focusing on. The bundle evolution came from nurses, by the way. Nurses putting together different techniques to reduce the amount of infections in this particular case. When we're looking at the different things that we do that we know reduce the transmission of bacteria, then that's what we want to do. We also know that hand hygiene is job 101. And interestingly enough, in examining hand hygiene years ago, and they're recognizing why are we not doing it so well? And advent of hand sanitizers at the door, at the entrance of the room, along with gloves, became the norm. Why did it become the norm? Because it was workflow easy. It made us do the right thing each time, every time, and we start practicing that pattern. I think we need to do that same thing now with the third hand being our stethoscope. And we have an opportunity now to make some changes in how we actually take care of our patients to prevent the transmission of pathogens from our third hand. So the idea of bridging this gap is clearly that quality chasm where we know what we want to prevent and we want not to happen, and then we have what is actually happening. And astute observation is the key. Your voice is the important piece because if it doesn't work with your workflow, it's not going to happen. We are going to be non-compliant and then there is going to be problems. And if you see something, you need to say something. This is not just a slogan for every other major trauma and catastrophe that happens on our planet, but this is really important for us at the bedside. If you're seeing something that's happening inappropriately, just as Kathleen pointed out, you come up with a plan of how to jerry rig something so that you can make it work better. This has been the nurses' activities from the get-go. We see things that aren't working right, and we figure out how to make it work better. But if you're just doing it one-on-one, we're not making it, expanding it big enough to affect the whole entire system. And that ends up turning out to be the idea. When you're looking at building automatic habits, this is a piece that I think really is part of our workflow as well. We know what things work. If you have a sink on the other side of the room and you're trying to wash your hands, it doesn't work well. Again, putting the hand sanitizer at the door and the gloves at the door. If you have a disc barrier for your stethoscope at the door where you can walk in, do these things in a 1, 2, 3 fashion and make it a habit, you end up having this become the norm. And once it becomes your norm, that proper technique feels automatic. More importantly, when you don't do it right, it feels uncomfortable. That is a good thing. That's what we want. So let's look at the whole process here with the ripple effect that happens. We have that frontline intelligence, what is right, what is wrong, and we have detailed insights as to what we need to do and change that. We have the tools being our checklist, we have guidelines as our framework for care quality, but these processes, again, have to be workflow compatible. If they're not, it's just not going to happen properly, and we know that. Then having the data that's associated with this measurements, because if you can't measure it, you can't improve it. And we need to know what's going on. This makes the financial viability useful for an organization, such that if they are dependent on publicly reported data and value-based purchasing as part of their reimbursement, it's really important for them to have these measures and see what we are doing right and what we are doing wrong. Again, your voice is the one that matters. So I like to talk about it as the N of one concept. We feel like, well, it's just me, it's my voice, I'm the squeaky wheel. You know what? Be the squeaky wheel, because as long as you're making it a positive squeaky wheel, not just complaining, your N of one is valuable. And that's what you want to make sure that it's like, this isn't working. How can we do this better? And why do we need to do this better? I'm using a lot of time, my precious nursing time, to do this thing, and it's not working well. So your N of one is critical. And I always like to compare this to peer review. When I was quality director, I had to look at the medical profession and how they did peer review. And we would look at cases and we would see how one physician would operate versus another. And we would compare the differences. Well, when one's having bad outcomes and the other is not, what is the difference in between? So having the N of one being initiation of that problem and voice is really, really important. So don't fear it, embrace it. Okay. This piece to me is extremely important when we're talking about human factors and near misses. I think most of us are familiar with human factors, but the near misses is the piece that's vitally important. How many times have you picked up a vial of some medication and you were thinking that it was one medication and it turns out to be another? I'll give the example of potassium and Pavulon. Those of you who know what those two drugs are for can clearly see what kind of a challenge that would be. The problem is if we see it and we say, oh, thank God I did not pull the wrong one and I gave the right one, that's a near miss. And that happens all the time. Same things happened historically with devices where we had both the tube feeding connector as well as ID connectors were the same. It only takes one time for that to be a catastrophe, but how many times before that did the nurse catch it and say, oh, thank God I didn't put that tubing together? These are the things that cause changes and innovation, and we want to do that. The traditional approach is looking at it after the fact. This is where the adverse events are counted and measured, and you do the root cause analysis to find out why it happened. We would prefer to work on the other side with success cause analysis, looking at these near misses where it almost happened, but it didn't, and start capturing that and seeing why we've been able to do this right. And what were those little jury rig things that we did in order to make this improve? This is where some of that insight and innovation can occur. And this is where I believe we have a great opportunity, especially here with stethoscope hygiene. It's such an obvious problem that you can clearly see, but are we actually capturing it and measuring it? And that is the piece that we'll talk about a little bit more on how to capture that. So, how do we make the easy mistake because of distraction, overworking, whatever, fatigue, et cetera, that's going on? We all know that these are problems. And I would encourage you, if you have never seen the Invisible Gorilla study, to look that video up. It's quite profound. When we are looking for something, we have a tendency to miss all of the other things. So it's very important for us. Your eyes will deceive you. And it's very important for us to have our brain on autopilot for all of the regular things, that habit stacking and doing it the routine way so that we see other things that are outside the norm and we can focus on it. And the other thing is developing processes so that we make the easy mistake practically impossible. If you have enough bumps in the road, you have connections that don't fit, you have color coding to make things obvious. We make enough problems to do it the wrong way that it makes it easy to do it the right way. And that helps us avoid those easy mistakes. So these are some of the processes that we want to work with.
All right. Well, thank you for that. I'm going to launch another polling question. And so, what we want to know is, have you ever experienced a near miss? And if so, did you communicate it to leadership? So, get your votes in.
Looking forward to seeing this one too.
Amen.
Okay. All right. 5 seconds. All right. Let's see what you said. All right. Okay. So 76% said yes, they communicated it and reported the near miss to leadership. Yes, but there was no communication. I experienced one, but didn't report it. And I have to say, I've fallen in that category so many times, right? Like, ugh, thank God, but I didn't report it, right? And then four people said that they've never experienced a near miss. So, all right. So with that, we're going to I'm going to hand it over to Kathleen, who's going to take it away and talk about this topic.
So, by the way, this is a wonderful chart. You have your handout in the course materials. Um, please print this because this really allows us to determine the effectiveness of our interventions. And with the amount of consulting I do and my practice at the bedside, as well as a clinical nurse specialist, oftentimes, and I want you to put it in the chat box if this is the case, you're working on a quality improvement project and all of a sudden the data drops down. What's the first solution everybody comes up with?
Education.
Go ahead, put it in the chat box. I'm watching. Yes. They need more education. They need more education. They need more education. By the way, guys, that is a red flag that your resources and systems are not built robust enough to make it easy for the staff to do the right thing. So as you get up, those are human-oriented people processes. You want to get towards the system-oriented processes. Now, I will tell you, it is very difficult to get a true force function in healthcare because of the multiple interactions. Let me give you more online modules. Sarah, you're absolutely correct.
Module to death.
Module to death. Some of you may be old enough to remember this, where you could actually take your keys out of the car while your car was not in park. It wasn't required to be in park. Can you imagine that concept of getting out of the car and it wasn't in park? That was not real safe. So the automotive industry did a pure force function, and that is you cannot stop the engine until the car is in park, period. So that's a safety feature. That's a true force function. So we're looking for ways to make our processes as close to automation, simplification, standardization, and reducing variation.
All right.
And so we've got to get away from this shifting of fix the nurse through they need more education, focus on individual error retraining, assume that mistakes are related to their incompetence, and really step back and go towards fixing the system instead. Focus on system design, environment, the workflow that we've talked about, recognizing those near misses as system vulnerabilities that we need to fix, using the human factor and process redesign, and proactive learning, like Cindy talked about, versus reactive learning of the RCAs. It's about creating a culture where we move beyond individual blame to an environment where the staff feels safe to report it. How many feel like your culture has started to move in this direction towards a fix the system versus the individual blame? Go ahead and put it in the chat box. I'm curious to see. I see some thumbs up going. That's good to see. Awesome.
A lot of people raising their hands as well. Yeah.
Which is
Maggie's
great.
saying a little bit. Yeah. At
A little bit.
times.
It takes a long time
Yeah.
for that culture to change.
That's for sure.
So, how do we go about designing systems to protect patients, regardless of us as humans? We've got to design it for safety. There's got to be a fostered environment for that open reporting that we've talked about. Applying proven frameworks, the plan, do, check, act, use of evidence. There's whether you use structure, process, outcome, plan, do, check, act. There's a ton of them that have been evaluated, and always have a nurse involved in the process because we are the closest to the patient. Without that nurse involved, systems are going to not be built the way they need to be. So when nurses lead system redesign, it really makes a difference, and it allows us to foster that innovation. And so now Cindy's going to talk about driving, taking that observation and moving it to innovation and how we drive it for change.
Thank you, Kathleen. I just want to put out a quick quote by Eleanor Roosevelt because I really find this important and I think it's part of how nurses operate. So, surely in the light of history, it is more intelligent to hope rather than to fear, to try rather not than not to try. For one thing we know beyond all doubt, nothing has ever been achieved by the person who says it can't be done. So, let's do it because we are the right people to do that.
And
But
Cindy, for a second, I want to address Melissa's statement in the chat box because that's really important. She feels like leadership is telling us it's safe, but she's not really seeing the changes completed. And that's where, and Cindy's going to talk in here about getting data and trending data. And that's something you can do right at the bedside with a couple of your peers. Just say 15 patients, let's collect data on this. It gets us within 3% of the routine way we provide care, and share that data back to leadership and say the safety's not there. Thanks,
thanks,
Melissa.
Kathleen. That's exactly what I'm going to talk about right now, as a matter of fact. So thank you for that, bringing that up, because that really is the crux of the issue. So in turning these observations into solutions, y'all had commented that many of you have seen near misses and have communicated that. The question I have for you is, how did you communicate that? We do a lot of verbal communication, bringing it to the attention of our managers, maybe to other nurses, et cetera, that, wow, I almost did this, et cetera. I had the good fortune of working in an institution where we did have a good culture and nurses were willing to come forth, and we actually measured the near misses. And in fact, we used the incident and event porting system to capture those near misses and then analyze them. And the interesting thing was, I was one of the hospitals in a system where we did this, and our goal was to get the near misses off the chart. We wanted that number of near misses being reported so high that we captured all of it. And what we found was not only did our near misses go up as we asked for it, and nurses' voices were being utilized, and we reported back to them what the findings were because we had the data. Our adverse events went down, and we were substantially less than the other hospitals in the system who then took on this same role to capturing near misses. And I think that this is really important because you can identify the gap, but how do you document it to get it into a report that now the hospital system and the leadership are willing to look at because we've got the volume? You may have a clinical nurse specialist. That's wonderful. You may not have a clinical nurse specialist. But what every hospital has is a quality director. It's required. There will be somebody there, and it is their role to be looking at the data. So I would definitely recommend that you share that data with those people and find out if your system can start capturing it in a way that makes it valuable for you to go ahead and move forward. Obviously, there's other ways of taking that data. SBAR communication, CUS methodology, safety huddles. The value analysis is happening all the time anyway with any kind of products and innovation within the system. And they're looking at that not just from the standpoint of does this product work, but also from the standpoint of is it cost effective? And I really want us to consider when we are providing this information, if we can capture it, like I said, for example, with incident and event reports and working with the teams that are associated with that, we can then move this data forward. Those incident and event reports are also required data. We have to report incidents and events. We don't necessarily have to report near misses. So use that as a concept to share with your teams as how we can move forward. Looking at the multidisciplinary collaboration, as Kathleen mentioned, it is not just a straightforward process. You may be the N of one, and your voice may be the start, but we will have to work together with multiple members of the team. I want to point out the fact that there is power in numbers, and way back when, another historical note, since Kathleen and I go way back when, and I can tell you that at one point, there were not nurse patient ratios in the hospitals, and California nurses initiated that by working together in communities. So it's not just right there in your unit. You can reach out to other nurses in your communities, in your state, in your other organizations to find out, is anybody else having this issue? And oh my God, I can't take care of 3 patients in the ICU. What are we doing about it? And working together with your nursing colleagues can really help to increase your voice and basically exponentially increase it. Clinical nurse specialists are trained in how to manage systems and elevate the standards of care and looking at the quality of care. If you have a clinical nurse specialist, they are somebody that you need to bring up these points to and let them do the work. They also are well connected with leadership and their voice matters. So it is very important to use them. By all means, your quality improvement teams, that is their role. Their core value to the organization is improvement. And when I say that, what I want you to recognize is the improvement piece, not just quality. We're not talking about the baseline measure. We're talking about that's the platform that we walk on. How do we make our numbers better? And management and leadership will listen to you when it's workflow time. The number one cost, as you can see in the pie chart here, for any healthcare system is the nurses, us. We are the care providers. We're the ones that cost money. So if we can reduce the amount of costs associated with our time, utilizing our time for valuable patient care as opposed to ancillary tasks that are necessary, yet taking up obnoxious amount of times, if you think about it, it is a way to reduce cost. And it is also a way for them to reduce the costs associated for, in this example, for infections. The less amount of infections, the less costs associated with that kind of care for length of stay, mortality, morbidity, et cetera. When we're trying to leverage some of our teams, one of the things that I always like to look at is the bell curve. Many people are used to the clinical trial data, for example, where they're looking at a massive amount and seeing what the changes are. When we're looking at quality, we're actually looking at the tail ends. We want to see, for example, on the left side, the 2% where there is a fair amount of errors. And on the right-hand side, the 2% where there's next to no errors. We'd like to see that whole bell curve shift to the right. The way to do that is the comparison of the far left side to the far right side. These are I these are individual issues that are happening. Your voice as the individual issues are happening at the bedside is where that happens. When we see these changes occur, it is very motivating to the nurses. We have an improvement via success as opposed to having the root cause analysis showing, I used to joke around that whenever I would walk down the hall as a quality professional, I had a target on my forehead and one on my back. They saw me coming and they wanted to shoot me. And as I was walking away, they were wanting to shoot me. And the reason was because I was having to do these root cause analyses, and nobody wants to be a part of that. If we can successfully change things to make it better, then that's going to ultimately be the ideal goal. Kathleen?
So we've got some case studies to be able to show this in action of what we're talking about. This one is, and Cindy alluded to this, drugs that look the same that may actually have similar wording. The system issue here is the similar drug name created confusion. They were stored together and the packaging looked alike. And so how did they fix this? Instead of the individual blame, which by the way started this process until there was enough, and they moved to a system fix where the hydro of the morphone was highlighted and morphine had it full caps and different font. They had pop-up alerts, separate bins to be able to distribute these, and the smart libraries, all as a way to reduce this. And this is an error that doesn't happen anymore. And we alluded to this one, the system issue of scrub the hub. How many of you actually, and feel free to put it in the chat box, actually counted the 15 seconds in scrubbing the hub, or went to your pocket to have an alcohol wipe, didn't have one, you were right there and just hit it. So supplies weren't in the workflow, busy environment. It was very difficult to monitor. So how did we fix that? It started out with a cap on central lines. And how many of you have now moved that cap to all lines? Because it makes sense in the workflow. It shows visible compliance, and there's time saving associated with this. So when compliance depends on human performance under pressure, then we know a redesign is absolutely essential in the process. Stethoscope. How many of you have actually seen people routinely clean the stethoscope between each use? And we know it's significantly contaminated. The compliance is not there on the cleaning, just like scrubbing the hub. And the use of disposable stethoscopes is inferior because we can't pick up all the rhythm dysfunctions. And do you want to use somebody's ears, same ears that sits in that room? By the way, people have gotten ear infections related to that. The system fix. Let's look at technology that makes it easy for us. We swipe it, we get a new cover, disc cover, we put it on the patient, we take it. So an implementation of a touch-free barrier. Again, using these case studies to take potential near misses of contaminated stethoscopes and implement an evidence-based practice. And I'm going to hand it over to Cindy to share a real life Your Voice Matters in action.
Thanks, Kathleen. Yeah, this was a really, really exciting opportunity, and I'm really looking forward to sharing with you all the details of this particular case, how a nurse champion basically engaged with this problem that they found in their institution, and it was related to CLABSI. CLABSI, and many of you, I'm sure, are using CLABSI bundles, and when you use those CLABSI bundles, you're you're practicing all of the different opportunities to prevent infection. And in the next slide, you see the different listing of those bundles. What the important part is that we've been looking at this and researching this for years. And the idea goal is to get those numbers down. And then you can see in this report that came out in June of 2025 in Critical Care Nurse, they had done everything right and they were measuring everything and they got down to 0.8, not to zero, not to zero. And the goal for infections is zero. We want no preventable infections to occur. They were so close. What was that missing link? And I venture to say that this case study that I'm going to show you here is going to talk to you a little bit about that. When we look at the Institute of Medicine has a quality improvement framework. I would recommend everybody get familiar with it. Not that you need to know it in detail because trust me, your quality people do. But that being said, it's pretty straightforward. You can read down it, and there's nothing in here that is not something that you don't already know. But that bedside nurses aha ideas will help champion these processes because you're the ones who have to say, did this work? And when it doesn't work, you're going to know it. It doesn't hit the nail on the head for any of these processes that are or any of these categories that are important in the quality improvement. So I'm going to talk to you about this study that was done at the VA in Memphis, and here's their disclosure here because they don't want to advocate for any product, service, or enterprise. It's the Department of Veterans Affairs, as we know. And the important piece is that these infection prevention nurses, one of which used to work in critical care, were had to report out the data that showed that they had 6 central line infections in less than a year, 3 in the medical and 3 in the surgical ICU. And they went to the bedside and lo and behold, found that the nurses were not doing the stethoscope hygiene protocol that they had put in place, which was wiping it down with alcohol. And you can imagine just like going to the sink and washing your hands for a full 20 seconds in between patients. It was not happening. So I'm going to go ahead and set this up and let you hear directly from the horse's mouth. This is the nurse that was actually doing this.
and then cleaning of equipment between patients. And that's when we spotted the stethoscopes. It turns out, as we mentioned in the prior, presenters mentioned that not many people are cleaning between patients. They are just not doing the proper hygiene for stethoscopes. And in our observations, and we're observing, they know we're infection prevention, and they know who we are, and they're trying to be on their best behavior. And even then, over half of the staff were not cleaning between patients.
So this infection preventionist is noting that they're not they're capturing the data and they're not preventing infections. So kudos to them for not just counting the data, but recognizing what the issue was so that they could look to doing different solutions. And what piece I want to point out here is alcohol wiping down in between stethoscope use with the different patients requires at least a minute, and it's not really functional anyway. It doesn't work well. That the data is in with that. Can we go on?
So when we reported this to leadership, they had a very strong and swift reaction. They pulled the plug on all personal stethoscopes and switched to disposable stethoscopes dedicated to each room. As you can imagine, these toy stethoscopes were not a big hit. It didn't sit well. The backlash was pretty swift, and leadership had to backtrack and reverse that decision, obviously. But what this did, this opened the door to something new. It was, the first time we had a real conversation about stethoscope hygiene.
So I think a few people may need to turn up their volume just a bit to hear, because it's a bit softer than our microphones.
So the point is here, they identified a problem, even with their own protocol, non-compliance. They looked for other solutions. Thank God leadership was even engaged and said, well, this is what we're going to do. And then let's take that back to the staff. And they say, I don't think so. So what this is showing us is this is the process that happens with quality improvement when you're looking at those individual cases as opposed to a big, giant, massive data. You have to go into the site, look and see what's happening, try different things and see what will work. So let's move on and see what they did next.
So the following year, we decided to experiment with disposable plastic stethoscope covers. We trialed those, like I said, 2019, and they sounded great in theory, but in actuality, they were honestly a real pain. They took time to put on, and in our observation, we really felt like they might be causing even more contamination when being removed.
So in this one, before we go to the next slide, I want you to note, you can see that they're not hitting the criteria for the quality improvement in any of these solutions. But again, kudos that they're even looking and trying to find a solution. What they did at this point was they did a literature search to see what other options were out there. And I want you to go ahead and move forward and we'll see what they did.
Because in 2023, we were introduced to a diaphragm cover for stethoscopes. And so that became the last part of our bundled approach. And this wasn't just any cover. It was, touch-free, very, very simple to use, easy to use. It didn't compromise any of the sound quality at all. And we just all thought that this is something that we can work with. The idea of decreasing contamination around the central lines, particularly those that are located, in the subclavian area, in the IJ area. And so, we'd had actually several infections with our permacaps, and they're generally located in that area. And so we just really could wrap our heads around this. And we had great feedback from clinicians as well. So we were, an additional benefit, we were able to phase out many of the disposable stethoscopes. So this very, very thrilled with the results. Since implementation of the entire bundle in August of 2023, we've only had one central line infection and since that time, and so that's 0 in 10 months, and we're still moving forward in that direction. And as mentioned previously, stethoscopes they really are like your third hand, and why it was such an added benefit to implement this system in our bundled approach to decreasing the central line infections. very, very, very pleased with it.
So I want to point out that I was so excited when this group of infection preventionists were brought to my attention, and I asked them if they would mind if I went ahead and put this in the AACN CSI community. And the CSI community was so excited about it that they asked them if they wouldn't mind presenting a poster at the NTI, which they did in May of 2025. This is um, Naomi Ragsdale on the left and Wendy Simpson on the right presenting their poster at NTI. What I think is important about this is you can see if you push the forward, you will see that they not only did they get down to zero, as they mentioned at 10 months, they have sustained the zero. So they are at zero. And that is fantastic. They found that adding this stethoscope diaphragm disc barrier to their stethoscope, to their CLABSI bundle, actually reduced their numbers down to zero. They were doing all of the other stuff, and many, many, many other reports that you see out there in the literature show the reduction, but they're not at zero. Zero is the only number that counts. That's the number that we're all targeting. So my question to you is how many of you are out there counting the months and years since your last CLABSI infection? And if you're not, then maybe you need to look at the missing link because let's face it, we're putting our stethoscopes up against the chest where all of their incisions and their lines, etc., are. And if you're not cleaning it adequately, which we can't do, you need to have a barrier to prevent that transmission of pathogens from one patient to the next.
All right. Well, and
Um,
and that's a lot of change that's driven at the bedside. So, okay.
And
100%.
we ended up putting it in an article so that we could help
Yeah.
that group disseminate their results, which is exciting.
And in fact, they have submitted for publication their that it should probably be coming out in the next few months, the whole entire story. So it's beyond the poster at this point, which the poster presentation is already published. And in addition to that, on the last slide, you did have the article, which is the review article Kathleen, Nicole, and I co-authored with Dr. Peacock. And that is, again, more data for you to use on why and how you can do it. Here's the important part in my book. You don't need to recreate the wheel. You don't need this to take you 2 to 3 years. The data's already out there. We know what the issue is. And one of the things that I used to say to my Hawaii colleagues all the time when we were leading the charge in reducing readmissions, which, by the way, we got down to the least amount in the nation, it is doable, is that we would steal shamelessly and share endlessly. Whatever you've learned, go ahead and share it. Whatever you see that you think will work, steal it. It's worth it. That's how we do the improvement. And we were fortunate enough to work with Naomi and Wendy to put together this stethoscope hygiene policy and procedure template. So you don't even have to steal it. It's immediately available to you in your, what did you call it, Nicole? The
Oh,
content.
it's in their course accounts. I'll at the end I'll show everybody how to find handouts and how to find the policy and procedure that you all worked on. So,
And it's in a Word document, so you can rearrange it, make it fit with your own individual policies at your organization. So
yeah.
bottom line is we want to have this, you doing this case study, you have the criteria there. This is what you need to do.
All right. Well, we're going to start wrapping it up. And what we're going to do now is one more polling question. And then Kathleen is going to lead us into like, how do we take the steps to actually implement change? And so here's our next question is, does your facility have a stethoscope hygiene process? And this is just like one of many things that, I think nurses can really help at the bedside and help change. But we wanted to give you like something that was like actually done at the bedside, driven a lot of it driven by quality with bedside nurses to implement change and reduce patient harm. So, okay, so the poll should have popped up. You've got 5 seconds to get your answer in. Okay, I'm going to end the poll. And it looks like most don't have some sort of
Yeah.
a standard hygiene process. So, okay. Well, we're going to start to wrap up, and Kathleen is going to drive it home now, and she's going to talk about how we advocate for change and tools and strategies to help us get there.
And thanks, Nicole. Really, it's packaging this for leadership. Partnering, as Cindy talked about, with the quality people, a clinical nurse specialist, a manager, literature review, so that you can find out what's out there. By the way, it's so much easier now with ChatGPT. Now, you do have to check the sources, but there are scientific ones that have been evaluated that are good, that help compile the proven effectiveness of what you want to do. There may be national guidelines you can use, and mostly there's also published literature about the cost savings. So let the evidence tell the story to where you can present a clear, compelling format that helps leadership in a very succinct way determine that this is an effective strategy. And so you got to speak the language. You've got to use the safety data that's in the organization. That's why you want to partner up with your quality individual or a CNS, leverage those near miss data. And then what I did was partner with the business office to see if there was real data at the hospital, not just literature data from a money perspective that I could use. Demonstrate how this can reduce workload burden for the staff through live demonstrations or a pilot experience, and find ways to standardize any process that you're doing so that you create a win-win solution for all stakeholders. And I'm not going to spend a lot of time on this because Cindy covered this, but tap your resources in the environment, your clinical nurse specialists, your educators, your managers, your quality directors. Become that improvement champion in your environment to make the best thing happen for you and the patients you care for. So to wrap it up in conclusion, and I know we're a few minutes over, and thank you guys for hanging in there, preventable harm will persist without your frontline advocacy. The human factors science requires process fixes, not blaming the staff. The science is overwhelming on that. Push back if you're getting individual blame. And bedside observations, your observations, can transform at the unit and the system-wide safety improvements. So the power of your frontline voice makes a difference. And I'm going to hand it back to Nicole.
Yeah. So that was our reference list. And so anyway, we just want to thank everyone for being here. We're going to take questions, but if you need to go, no problem. But when you signed up, you were put into like a course account. And to do your evaluation, there's going to be on the left-hand side in your course account, it'll say course evaluation and CE. So you'll just do a quick evaluation, and then you need to either save onto your computer or print your CE certificate. So just kind of make sure you're on a computer that will allow you to do that. And then in your course account on the left-hand side, you need to make sure everything gets marked as complete. So literally all you do is click on course evaluation and CE, and then go to the middle page and click complete. It's super, super easy. It should take you literally just seconds. And then the slides are in the hand are from the presentation are in your course account. They're under the left-hand side where it says download course handouts. It is there. And then we also put the policy and procedure template there for, like, for example, like stethoscope hygiene. And then we are going to upload the recording of this session today. So we're going to make this recording available for the unforeseeable future. So if you have anybody at your facility who you think this would benefit them, just you can just send an email to me, or you can on my website, I will also have this posted. So it will definitely be available. We want to spread information. It's absolutely free. So just want to thank everyone for being here. So with that, we will take any questions. So to send a question, you can either write something in the chat or the Q&A. And so we will definitely take questions. But again, I want to just thank Kathleen and Cindy for being here today and sharing your knowledge. Change it's hard. Change is definitely hard, but we know we're constantly should be driving the ship toward hospitals being a very safe place to be. And I know this summer, a lot of you know, I was a patient and I had two big surgeries for endometrial cancer. And I'll tell you, I just, it's very a vulnerable position to be in as a
Exactly.
patient. And you want to know that hospitals are the safest place you can be. So, all
Well,
right. So,
and guys, really think about joining the campaign to raise stethoscope hygiene awareness. Do this QR code because it's important that we change the narrative on something that is as significantly challenging as hand hygiene was in the 90s before the alcohol-based hand hygiene.
yeah. All right, so I have a
Absolutely.
question for you both. That's from Melissa. So Melissa says she feels like they're becoming very reactive at the bedside and not proactive because they don't have time to do everything, and they're supposed to be doing for patients. So nurses are picking and choosing what they complete. We have been talking about staffing needs to be looked at, but I'm not even sure where to start. Any suggestions? I know this is not solely on her unit.
One of,
You know,
oh, go ahead, Cindy.
I was just going to say one of the number one things that we look at if you recognize nurses' time is valuable and it is what cost money. And if you're looking at the things that you're doing that are causing you frustration, that are wasting your time, like for example, spending a minute trying to clean a stethoscope, if you can find the voice to have that this is amount of time, it does help them understand how they can reduce the burden of your work. It's that 5 minutes of prevention worse is better than doing the hour of work on the back end. So if they're getting infections and they're increasing length of stay and they're increasing their morbidity and mortality, all of that is additional work. And you're already short staffed. We don't need that. So it's a concept that I would, again, work with your clinical nurse specialists, your quality directors, et cetera, to help get that voice there because you are so overburdened. But when you identify those issues that are workflow obstruction, causing you to take more time and have less ability to care for your patients the way that you want to, those are the issues that need to be brought up. And you don't always have the time to champion it. That's why you need to have your colleagues working with you on that.
So, Melissa, one of the things that we did to start that journey, because I heard this, by the way, even in the 90s, we've gone
Hmm.
through multiple cycles of not having enough staff. Um,
Hmm.
what we did is we sat down together as a group. It was with our unit governance council, but you can do this with staff. We put the patient in the center and we said, what are we doing that has no evidence, nothing to support it, that is just routinized behavior that we've done forever in the environment, and can we get rid of it?
And it can be looking at a different type of staff. I mean, I remember when we didn't even have medical assistants. We had to clean our own equipment. I mean, talk about a waste of nurses' time. So you'll see, just like Kathleen pointed out, there are things that we're doing that either are not valuable or could be done by somebody else, or of, that doesn't require a professional license so that it can allow you to do the top quality care.
So I
And
hear what you're both saying, but I think like so practically, so Volman, so you're saying get like basically like a staffing, do it as a group. And so like with something like Melissa's describing, who would you suggest she gets involved? Because I think this is a complaint in a lot of units.
yeah,
Sarah is saying that AA-SAN staffing guidelines are a good place to start. I totally agree because the data is really clear. If you don't have enough, for every patient a nurse gets assigned to their caseload, the risk of death actually increases. There is really solid evidence on
right.
that. So, who
Mhm.
do you get involved then when you're just feeling like staffing is a major issue? Who did you get involved, Kathleen, when you
So,
did this?
So it was the manager first,
Yeah.
and we put the case together. That we looked at our data when our staffing was better, our quality data, and we used that. Now we used it to prevent them from cutting us further because they wanted to reduce our staffing. This was when they balanced the budget on the back of healthcare in the 90s. So it was a different framework, but we used our quality data to say, hey, we don't have enough humans and our infection rates are going up. Our pressure injury rates are going up. We
Yeah.
need to creatively think about. So I use, together with the staff, one, I looked at routinized behavior that didn't have any benefit to anybody.
Can you think of anything specifically that you all got rid of that like was just a waste of
Well,
time,
well,
basically?
there are some patients in the ICU that don't need hourly vital signs.
Let's start there. Because even documenting, let's be honest, when by the time you sign in, you get to the worksheet, like that takes a couple minutes, right?
So we created structure standards, minimum structure standards for practice in our unit
Mhm.
based off the evidence.
Yeah.
So we got rid of, stuff that people routinely did. One, we changed the way we bathe. That was from a 20-minute to a 5-minute by, plus it improved the care in the
Yeah.
fact that we reduced infection rates. So we looked at different things. We also made sure that some of the work that was routine that needed to take place got divided equally so that it wasn't always on the day shift or wasn't always on the night shift with the
Yeah.
patient in mind though. So we didn't wake
Yeah.
people up at 3:30 in the morning to bathe them. And
That
as
which is
Sarah,
ridiculous. Yeah.
yeah, and Sarah, you're absolutely correct. Charting by exception. I got to tell you, they need to blow up the EHR. Talk about inefficiencies. I've been in these
So,
systems now.
interesting to that point, back in 1985, when I actually had an opportunity to be a part of the first EHR in San Diego County, which was Clinicomp, and it was designed by the SICU nurses, four of us.
Yes.
And all we said was, we want the flow sheet to look just like our paper one and have all that data come in automatically, where we were measuring vital signs every 15 minutes. If you can even imagine just the writing it down that frequently. And you're right, the EHR is a part of it. But at the end of the day, if we can work with the people in our units, finding those bedside nurses that can have their voice shared with their managers, ones that are willing to do the work, not all of them are, clinical nurse specialists, that is part of it, and the quality team. I really believe that gives you the access to the data, to the process, and you as a bedside nurse don't need to do all that work and that championing. You are a part of, and your voice is what is the crux and the most important issue. There's 1,000 issues that we can address, but as the bedside nurse, you all you need to do is really identify those pieces that are really hard and help get that to the front, to the management team, the leadership team, the quality team, so that they can help lead you through this process, because it is really ridiculous. You're overburdened for sure.
Well, and I don't think as a bedside nurse, I'd always think about getting quality involved, right?
Right.
But that is the group who collects a lot of data on patient outcomes. And it's patient outcomes and costs that's going to really help drive change in improving staffing and things like
Yeah,
that.
and their whole core value of quality is the value-based purchasing, the financing of the organization. That is what they do. They not only collect the data, they look at how can we make it better so that we get better reimbursement. It's the crux of their existence.
Yeah.
Take advantage of it.
Yeah. All right. So Sarah's saying can also look at expensive hiring, training a nurse to replace a nurse that leads to moral distress and things like that. Yeah,
Right.
And we
absolutely.
actually did that. We
That's
did that.
Yeah.
huge.
We put
Yeah.
it together with our entire quality
Hmm.
story of reducing infections and pressure injuries and also
Staff turnover.
retention of
Yes,
staff and how much money was
exactly.
saved.
Yeah.
Yeah, I know when
Happy
we went
staff are
through big
happy.
growing pains, we actually started in our unit a mentoring program where, and this was all nurse driven at the bedside, where we got approved for time off the unit. So, like as an experienced nurse, I would get assigned a newer nurse. And we, for 1 year, we had approved 4 hours a month that we could meet outside of work for me to mentor this person
Oh,
so that
that's
they
awesome.
felt like they belong. They had a clinical person and a buddy. And what we did find is that it helped our retention rates.
Another little point, because I used to be the critical care clinical educator for you educators out there. When you're bringing in new staff or staff from other facilities, and they're telling you, well, we used to do it this way over here, we did it this way over there. You are in the prime position to be collecting that data. Again, steal shamelessly. Oh, well, that's a good idea. Maybe we need to look at how we can do that here. And as an educator, not only are you providing the education to how we do it here, etc., you are in a perfect position to share with, this might be an opportunity to do it better because it worked over there.
Yeah.
So reaching out to your colleagues at other institutions and your associations, AACN, California Nurses Association was great. They had all kinds of opportunities for us to share. I think that these are ways that you can gain momentum and take the burden off of just you. It is really hard to do this as the N of one, but boy, your voice counts and it can make the difference in changing the way that things happen for the future. And who
Well, I
knows, you
want to
might
thank
be the next
everyone for
patient.
being, yeah, I want to thank everyone for being here today. We're going to wrap it up, but a huge thank you to all of you. We're going to follow up with, we had some questions. I guess the QR code is incorrect, so we'll send out the new link, and then we'll send up a follow-up email just identifying where the handouts are and things like that. But just a gigantic thank you to everyone for being here today. And again, if you feel like there's anyone in your facility that would help, by listening to this webinar, we will definitely forward it to anyone who would benefit from it. So,
And by the way, our email addresses are there for a reason. If you
Yeah,
have that
feel free to
voice
use
and you
them.
need some coaching.
Yes.
all right. Yeah. All right. Well, again, just a gigantic thank you. Mary, hopefully everybody has a great holiday and an awesome December. So thanks to everyone for being here today.
Mahalo.
Bye-bye.